My name is Muhammad Ibrahim. I'm lecturer at the University of Hargeisa. In this presentation, I will talk about ultrasound evaluation of the scrotum. Ultrasound is the modality of choice for evaluating the scrotum. And despite the more sophisticated imaging modalities, ultrasound remains the first line and frequently the only imaging modality used in the assessment of scrotum abnormality. I will discuss the anatomy of the scrotum, scanning techniques, and most common scrotal abnormalities. The scrotum is divided into two longitudinal chambers by fibrous scrotal septum. The wall of the scrotum is made up of many layers. Here is the skin. It is thin. The next is superficial fascia. It is continuous with the fatty and membranous layers of fascia of anterior abdominal wall. Next is spermatic fascia. It is derived from three layers of anterior abdominal wall: external spermatic fascia, cremastic fascia, and internal spermatic fascia. Beneath the internal spermatic fascia is the parietal layer of tunica vaginalis. Here is the visceral layer of tunica vaginalis, covers the tunica albuginea. Tunica albuginea covers the testes. There is potential space between the parietal and visceral layers of the tunica vaginalis, contains 2 to 3 millimeters of fluid. Testes are ovoid gland covered by tunica albuginea, projects internally to form septa that divides testes into lobules. The septa converge posteriorly to form mediastinum testis. The lobules contain seminiferous tubules. The seminiferous tubules converge posteriorly to form a network of channels called rete testis. The rete testis is located within the fibrous mediastinum testis. 10 to 15 efferent dactyls emerge from the rete testis and convey signal fluid from the testis to the head of the epididymis. The epididymis is curved structure, consists of head, body, and tail, measuring 6 to 7 centimeters in length and laying posterior lateral to the testes. The head contains 10 to 15 efferent dactyls from the rete test. These ducts join together to form a single convoluted duct. The duct epididymis has a very tortuous route from the head to the tail of the epididymis, where it turns around to exit into the spermatic cord from the epididymal head. The duct is called vas deferens or seminal duct as it emerges from the tail to the epididymis. The vas deferens exits the scrotum as part of the spermatic cord. Vascular anatomy. The arterial supply to the scrotal sac and contents arise from three sources: the testicular artery, the cremastic artery, and the artery to the ductus deferens. The testicular artery is a direct branch of abdominal aorta that enters the scrotum through a spermatic cord. The cremastic artery is a branch of inferior epigastric artery supplying the scrotal sac and coverings of the spermatic cord. And the artery to the ductus deferens arises from the superior vesical artery. Testicular veins pass through the mediastinum as they exit the testes. The network of veins posterior to the testis is called the impiniform plexus. Each plexus of veins eventually forms two testicular veins which form a single testicular vein. The right testicular vein drains directly into the inferior vena cava below the level of the right renal vein, whereas the left testicular vein drains into the left renal vein. The plexus of veins plus the three arteries of the testicular, cremastic, and deferential arteries, in addition to the lymphatics, nerves, and vas deferens, all of these are loosely held together by a connective tissue in the spermatic cord. The spermatic cord runs from the deep inguinal ring into the scrotum. Before scanning the patient, it's important to determine the clinical findings. Why the patient was referred? Is it due to the palpable mass, scrotal pain, swollen scrotum, or other reason? Ask the patient to describe symptoms, including history, location, and duration of pain. Also ask the patient if he can feel a mass. If yes, then tell him to find the lump. Place the probe exactly over the location to examine the site. Again, ask the patient if he had trauma, when and what happened. This information is necessary not only for guiding the examination but also for interpretation. Scanning techniques. The patient is supine. The penis is held by the patient against the abdominal wall. The patient is asked to place his legs close together to provide support for the scrotum, or rolled towel might be put between the two legs. Plenty of gel is applied to ensure adequate probe contact and to remove air between probe and skin surface. High frequency of 7 to 14 MHz linear array transducer should be used. Color and spectral Doppler is very helpful, as we will see later. The entire scrotal sac should be examined in order to include both transverse and longitudinal planes. Sonographic appearance. The scrotal wall appears as 3 layers. This tunica vaginalis parietal layer, this tunica vaginalis visceral layer, and this tunica albuginea. What's important here is to note if the skin is thickened. Normal testes are homogeneous in echo texture with uniformly distributed medium level echoes. Size and echogenicity of the two tests should be identical. When you are scanning tests, think of these questions. Is the parenchyma homogeneous or heterogeneous? Is there a mass? If yes, is it cystic or solid? Is it intratesticular or extratesticular? This sagittal view showing mid and lateral portions. 2 measurements are obtained in this view, the length and depth. The transverse view is to show superior, mid and inferior portion. The width of the test is measured in this view. In adults, testis measures approximately 3 to 5 centimeters in length, 2 to 3 centimeters in both depth and width. This is the mediastinum, appears as highly echogenic linear structure that extends cranicaudally within the testis and parallel to the epididymis. It is draining the seminiferous tubulus of the testis into the reta testis. This is the reta testis, appears as low reflective area at the hilum of the testis with finger-like projections into the parenchyma. This is the intratesticular band, also known as vascular cleft. It is hypoechoic band in the middle third of the testis, nearly perpendicular to the mediastinum on sagittal scans. This band is visualized in about 10% of normal testes and is measured up to 3 mm in diameter and 30 mm in the length. The band is caused by a prominent artery and vein called the transmediastinal vessels. It can be easily seen with color Doppler. The appendix is usually seen when there is fluid. It is normally a small, round prominence extended from the upper ball of the testis. It is only 1 to 3 mm long and isoechoic with the testis. This is the epididymis, isoechoic with the testis, and its echotexture might be coarser. The head normally measures 10 to 12 mm in diameter and lays lateral to the superior bone of the testis. The body is here extended inferiorly from the head and is found posterior lateral to the testis. The normal body measures less than 4 mm in diameter. The body is hypoechoic and often is defined only by its right anterior and posterior walls. The tail and the appendix epididymis are not routinely seen unless there is hydrocele. Pathology. Here is the list of scrotal pathology we will discuss. We will begin with the congenital abnormality of undescended testis. Undescended testis is also known as a cryptorchidism. Is the failure of testis to migrate from abdominal cavity through the inguinal canal and into the scrotum. Approximately 80% of undescended testes are located within the inguinal canal, and only 10 to 25% of cases are bilateral. Surgical freeing of undescending testes and implanting into the scrotum is known as orchiopexy. If orchiopexy is not performed in early age, the descended testis is usually hypospamic and atrophic and results in infertility. The risk of malignancy is up to 8 times more in the undescended testis than the general population. The orchiopexy will not reduce the risk of malignancy, but at least it will help the lump to be detected and treated earlier. Also, testicular torsion is more common with undescended testes. This is an example of undescending left testis, small and hypoechoic. It is seen next to the internal inguinal ring. Another example of inguinal undescended test in a 3-year-old boy with a single palpable test. Testes are elongated and relatively decreased in echogenicity. Epididymoorchitis. Epididymoorchitis is infection of the epididymis and testes. It is the most common cause of acute scrotal pain in adults. It predominantly affects the sexually active male of less than 40 years, the older patient with urological disease, and the prepubertal boy with associated urogenital anomaly. Sonographically, epididymis will appear hypoechoic gland. Sometimes there might be reactive hydrocele, hematocele, or biocele with septations and scrotal wall thickening. On color Doppler, there is increased follow as mark of hyperemia, which confirms the diagnosis. If infection is spread to the testes, it will cause the testes to appear enlarged on ultrasound. Affected areas may appear as hypoechoic compared with the surrounding tissue, and this will result in heterogeneous appearance of the testes. On color Doppler, there is increased follow. This epididymis, enlarged and heterogeneous texture. Here is complex hydrocele with many septations. Color Doppler shows hyperemic follow within the epididymis. This is an example of orchitis, focal area of hypoechoic. It might look like infection or neoplasm. And this diffuse orchitis, the test is swollen, scrotal skin thickened, and parenchyma shows patchy areas of low echogenicity. And here increased color Doppler signal shows hyperemic follow. This appearance might persist for several months following treatment. Sometimes difficult to exclude neoplasm or malignant lesions. So it's important that diffuse and focal changes of the testes, especially of orchitis, to have follow-up scan to ensure complete resolution and to rule out neoplasm. Scrotal trauma. The most important goal of ultrasound in testicular trauma is to determine if there is rupture, because rupture of the testis is a surgical emergency that requires immediate diagnosis. On ultrasound, we see discontinuity of the tunica albuginea, irregular heterogeneous testicular margins, scrotal wall thickening, and hematocele. Hematoma might be seen displacing the associated testes, initially as high reflective area, but subsequently as low reflective complex cystic structure. And in this case, color Doppler might be helpful in differentiating of hematoma from other masses by identifying it as area of no flow. This is an example of testicular rupture. Here we can see interruption of tunica albuginea and extrusion isoechoic lesion representing the testicular contents. The surrounding hypoechoic lesion is suggestive of hematocele. The subcapsular hypoechoic lesion is subcapsular hematoma. No follow signal is seen in the extruding isoechoic lesion, and here surgery confirms testicular rupture with extruded testicular contents covered by hematoma. Another example of testicular rupture. In this area we can see loss of the tunica albuginea and extruding heterogeneous, less echogenic lesions. And this image of surgery confirms what is seen on ultrasound. Spermatic cord torsion. It's when spermatic cord is twisted and the vascular supply is cut off. Usually it's due to the abnormal mobility of the testis within the scrotum. The main cause is bell-clapper deformity. Normally the testis and epididymis are surrounded by tunica vaginalis, except the bare area where they are attached to the posterior scrotal wall. The bell-clapper deformity occurs when the tunica vaginalis completely surrounds the testis, epididymis, and distal spermatic cord, allowing them to move and rotate freely within the scrotum. This movement is like that of the clapper inside the bell. This is hydrocele within the tunica vaginalis. The There is no fluid posterior to the testis because of the absence of tunica vaginalis in this area. And in this case, the testis is completely surrounded by hydrocele, hanging the extremity of the spermatic cord. This patient is at high risk for spermatic cord torsion. Spermatic torsion is surgical emergency, and it's important to obtain the diagnostic images as quickly as possible because the salvage rate depends on the time of the surgery. If surgery is done within 5 to 6 hours of the onset of the pain, 80 to 100% of the testis can be saved. Between 6 to 12 hours, the salvage rate is 70%, and only 20% will be saved if surgery is done after 12 hours. Clinically, torsion might present like epididymal orchitis, pain and swelling of the scrotum, so ultrasound, especially color Doppler, is important in differentiation between the two. Ultrasound findings depends on the time passed since the torsion. In early stage, scrotal contents may have been normal. After 6 hours, the testis becomes swollen and hypoechoic. After 24 hours, this becomes heterogeneous as a result of hemorrhage, infection, necrosis, and vascular congestion. The most important feature is the absence of color Doppler follow in the symptomatic tests compared to the asymptomatic tests. This is an example of early testicular torsion. Left test appears swollen and mild hypoechoic hydrocele is present. Here is another example of testicular torsion. After 12 hours, it is heterogeneous in echotexture and edematous. This is a twisted spermatic cord. It is rarely seen like this. Enlarged twisted spermatic cord, superior and posterior to the epididymal head, containing round anechoic structure representing a vein resembling a whirlpool, and this is first described with MRI imaging. This secondary is between normal left testis with the towards right testis. In the left we see follow-on colored Doppler, whereas in the right there is no follow in the testis. Make sure the same setting of the colored Doppler is used in both testis. This is another example of normal test compared with the towards one. Here there is follow and here there is no follow. Hydrocele, biocele, and hematocele. This develops at the potential space between the visceral and parietal layers of the tunica vaginalis. Normally there is a small amount of fluid in this space. Hydrocele contains serous fluid and is the most common cause of painless scrotal swelling. Hydrocele may be associated with trauma, torsion, infection, tumors, even can be idiopathic. So hydrocele is non-specific indicator. Sonographically, hydrocele is an anechoic fluid collection surrounding the testis except posteriorly when the tunica vaginalis is absent. Hematocele and biocele are less common than hydrocele. Hematoceles can be caused by trauma, surgery, diabetes, neoplasm, or torsion. The biocele results from rupture of an abscess into an existing hydrocele or directly into the space between layers of tunica vaginalis. Both hematoceles and bioceles contain internal echoes and are associated with internal fluctuations and loculations. The clinical history usually allows differentiation between the two. Varicocele. Varicocele is an abnormal dilatation of the venous of the bambiniform plexus located within the spermatic cord. The varicocele is present in up to 15% of asymptomatic adult patients and 40% of infertile men. 78% of it is in the left side, 6% is in the right side, and 15% is bilateral. So this abnormal dilatation of veins arises more often on the left, and many authors refer this to the angle at which left testicular vein enters into the left renal vein. Left spermatic vein empties into the left renal vein at right angle, which might cause the valves to be incompetent and allow retrograde flow, resulting in dilatation of the bempiniform plexus of veins. The normal veins of the bempiniform plexus measure 0.5 to 1.5 millimeters, and vein diameter of greater than 2 millimeters should be considered abnormal. On ultrasound, a varicocele shows multiple tortuous tubular structures of varying size. This seems superior and lateral to the testes. You can see sometimes varicoceles becoming more prominent. This one patient performing Valsalva maneuver. This is another example of varicocele. You can see with Valsalva maneuver it will appear more clear. Scrotal masses. Ultrasound is extremely sensitive in detection of testicular masses, and its primary role is to determine whether mass is intratesticular or extratesticular, cystic or solid, because intratesticular solid mass must be considered malignant until proved otherwise, and the majority of extratesticular mass are benign. Benign testicular masses. Intratesticular cysts are quite common in men older than 40 years. It is an incidental finding on ultrasound, found in 8 to 10%, and it's usually located near the mediastinum. Cysts might be single or multiple. It is of variable size. On ultrasound, it appears like any other cyst in the body, round or oval in shape, anechoic with posterior enhancement. This is a cyst located within the dense tissue of the closely adherent tunica albuginea. These cysts are usually palpated by the patient as thin nodule on the surface of the testis, and this is cyst at the head of the epididymis. Tubular ectasia of the rete testis. It is dilatation of the testicular mediastinal tubules. The rete testis is located at the hilum of the testis where the mediastinum resides. Cystic ectasia of the rete testis is uncommon benign condition. This results from the partial or complete obstruction of the efferent duct, often by inflammation or trauma. It is usually associated with the presence of spermatocele, epididymal or testicular cyst. On ultrasound, normal rete testis may not be seen. Tubular ectasia appears as prominent hypoechoic channels near the echogenic mediastinum. This may resemble intratesticular varicocele, and here color Doppler can differentiate between the two. This panoramic view of the right and left test shows dilatation of the rete test on the left side. Scrotal hernia. It might contain small bowel, colon, or omentum. Usually clinical examination is enough, but ultrasound may be useful in difficult cases. On ultrasound, the hernia contains bowel or omentum, giving rise to peristalsis of fluid-filled lobes of bowel, air within the bowel, or high reflective omental fat. We can see in this clip peristalsis of intestine inside the scrotum. Malignant masses of the testes. Testicular carcinoma represents only 1% of all cancers in men, but it is the most common malignancy in the age group of 15 to 35 years. Fortunately, it is curable and survival rates approach 95%. Risk factors for testicular carcinoma are previous testicular tumor, family history, cryptorchidism, and infertility. Most patients present with painless lump and testicular enlargement. In general, testicular tumors are divided into germ cell and non-germ cell tumors. Germ cell tumors constitute 90 to 95% of intratesticular primary tumors. It is subdivided into seminomas and non-seminomas tumors, with seminomas constituting 40% of germ cell tumors. Mixed embryonal cell tumors and teratocarcinomas are the most common non-seminoma neoplasm, constituting 25% of germ cell tumors. Other non-seminoma neoplasm include yolk sac tumors, choriocarcinomas, teratomas, and various combinations of these cell types. Seminoma is the most common cancer of the testis in adults and the most common tumors associated with the cryptorchidism. Seminomas are radiosensitive and respond well to therapy in more than 90% of patients. The typical sonographic appearances are hypoechoic, homogeneous, solid mass. It has a well-defined round or oval shape and can be multifocal within a test. Also, it may be present in atypical appearance as heterogeneous, lobulated or multinodular areas and may be difficult to differentiate from testicular infarction, torsion or abscess. And in these cases, clinical history may be helpful. This is small seminoma with characteristic appearance, homogeneous and hypoechoic. Your testis is mostly replaced by a solid hypoechoic mass with a well-defined margins and homogeneous echo pattern. A rim of normal testicular parenchyma surrounds the mass. On canal Doppler there is fellow showing feeding vessels. The non-seminoma germ cell tumors is a collective group of various cell types, affect the younger patients and more aggressive. Their appearance on ultrasound reflects the diverse nature of histology, but commonly it shows heterogeneous, with hypoechoic areas likely corresponds to areas of hemorrhage. Margins are irregular and poorly defined. This mixed germ cell tumor contains more than one germ cell. The most common combination is teratoma and embryonal cell carcinoma. Heterogeneous is slightly more echogenic and is not as clearly defined as seminoma. This pure embryonal cell carcinoma, it is the most aggressive primary germ cell tumor, heterogeneous, lobulated, well defined in some areas and poorly defined in other areas. It is here invading the tunica albuginea and have cystic components and echogenic foci. And this is an example of teratoma, a large teratoma occupying large area of test, heterogeneous, somehow well defined, and there are cystic changes. Non-germ cell tumors represent around 5% of all testicular neoplasms, with a higher prevalence in the pediatric age group. Nearly all non-germ cell tumors are benign. There is no clear sonographic appearance that allows differentiation from other testicular tumors. These non-germ cell tumors contain Leydig, Sertoli, fecal, granulosa or lutein cells and fibroblasts. And combined with other cell tumors, it is called gonadoblastomas. Secondary testicular tumors starts in another organ and then spread to the testicle. Lymphoma and leukemia are the most common secondary testicular cancers. This is an example of lymphoma. There is enlargement of testis with a mass of uniform, low echogenicity appearance. A surrounding hydrocele is present in a patient with testicular lymphoma. And this is an example of leukemia, an area of low echogenicity in a patient with acute myeloid leukemia, and there is a small hydrocele here. Testicular microlithiasis. Testicular microlithiasis describes the appearance of multiple tiny bright foci measuring 1 to 2 millimeters in diameter, which may be unilateral or bilateral. Acoustic shadowing is not seen usually, probably due to the small size of the calcifications. Studies show that between 1.3 and 6.2 of people with infertility have testicular microlithiasis. 6.7 of patients with cryptorchidism have also testicular microlithiasis, and tumors are found in up to 44% of people with microlithiasis, the most common of which is seminoma. This longitudinal and transverse of testis with well-defined, non-shadowing, punctate, echogenic foci. Finally, let us summarize what we have discussed. We reviewed anatomy of the scrotum, its normal and sonographic appearance. We discussed common scrotal pathology, including congenital anomalies, infection, trauma, and scrotal masses. Thank you.